Actually, just a few words. This is our 8th online webinar
Meetings. Yes.
on spine updates, and the moderator is Dr. Salim Şentürk, and we will talk about the lumbar spine stenosis surgical techniques. Yes, Salim, it's your time.
Thank you. Welcome, everyone. Today we will talk about spinal stenosis, surgical techniques for spinal stenosis. And we talk about 3 techniques: tube-guided surgery, endoscopic surgery, and microscopic surgery. And first of all, I think we may start Dr. Kim. Welcome, Dr. Kim. If you want, we may start. If you...
Okay, thank you so much.
Okay, welcome.
Can I share my slide? Yeah, you can see my slide?
Yes.
Okay. Okay, you can see.
Yes, good.
Okay. Thank you so much. It is my great honor to give a lecture in the 8th WFNS Spine Committee Zoom meeting. This time is we will discuss about lumbar spinal stenosis decompression surgical techniques. I'm Hyeun-Sung Kim, Harrison Spinal Hospital, Cheongdam, South Korea. I already experienced about 3,000 cases of endoscopic decompression. Today, I will discuss about uniportal endoscopic lumbar decompression procedures. Yes, we already well known that degenerative spinal disease before time, we mainly discuss about disc herniation, but with the increase of people's mean life so rapidly, the lumbar spinal stenosis become a very, very important portion of not only spinal disease, but also in medical point. And also, fortunately, endoscopic spine surgery firstly starting from the only the discectomy targeted, but nowadays some instrument developed so much like like this large scope and like this arthrocare and the radio frequency system and the good drilling system. Because of that, nowadays we can expand the indication of the endoscopic spine procedures so widely, not only degenerative spine, but also so many spinal pathologies. In this paper written by me, 2019, the evolution of the spinal endoscopy, before time, so long time, we only focused the discectomy pathology for endoscopic spinal procedures. But with the development of the endoscope procedures, not only portal, but also biportal, the third generation of endoscopic generation become endoscopic decompression. There also can possible to expand the indication not only decompression but also fusion and also thoracic and cervical pathology together. Actually, the endoscopic decompression, especially uniportal procedures, firstly introduced by Professor Sebastian Rett in 2009. But actually, the commonly used this paper, my paper written 2017 of the contralateral over the top technique introduced for in all the neurosurgery, and also introducing the contralateral foraminal approach. That time, the endoscopic decompression more widely spread and more widely indicated, applied. And also, this endoscopic decompression development also can possible to expand the indication like this cervical pathology. This technique also introduced by me, partial pediculotomy, partial vertebrotomy technique. And also after that, we can more easily apply the more to the many pathologies of the cervical pathology and more good clinical result we can take. And also After then, we can try this endoscope technique to the endoscope lumbar interval fusion. This paper also written by me. And also, this paper published in 2022, the thoracic pathology also can possible endoscope decompression, and it means that the near all parts of degenerative disease can possible by the endoscopic approach. And also, this paper also written by me 2019 in Neurology India with the all indicated all degenerative disease, we can possible more than 95% degenerative disease can take good to excellent clinical result. And because of that, endoscope spinal stenosis decompression before time, the tubular surgery and open surgery performed mainly. We should know that what is the rationale of the endoscopic decompression compared to the previous procedures. Yes, we can check it here. Actually, the endoscope procedures is more, you can say, like a mobile angled approach. Because of that, we can approach more easily to the more deepest point. And also some another important differences is that the operating field is more close to the target point. Because of that, we can more detailed procedures can possible. And also some another advantages that we can use the water irrigation procedures because of that the operation field very clear and more deepest and more detailed point. We can more cautiously and more detailed process is possible in spite of the some very complicated point. And also some another more important advantage is that you can see here like this. Yes, you can see these cases of very severe spinal stenosis. Like this cases before time, we need some wide decompression with sufficient facet resection. Because of that, it have so much facet damage and so much muscle damage, because it may be higher chance of the second instability and some another complication during the procedures. But if the endoscopic decompression may be expert, we can take like this image taken one day after operation. You can see the bilateral facets have near completely in spite of the sufficient decompression. Not only you can see the paraspinal muscle preserved completely. This is our real goal to the spinal stenosis decompression. Because of that, we can, in spite of the sufficient neural decompression, we really preserve the functional segment, not only lateral but also bilateral, and minimizing the paraspinal muscle damage, less neural detection, and then we can possibly increase the people's normal life activity return. Now we check the operative consideration. And I already mentioned that before time we used only small endoscope, but nowadays some development of the endoscopic tools, instrument, nowadays we can use the more larger endoscope possible, because of the endoscope decompression and more hard bony work is more easy nowadays. And also on another development is that the endoscope drill and the radio frequency system, not only the radio frequency system, but also arterial care system can help to manipulation of the hard tissue of the bony manipulation and soft tissue of muscle and the ligament manipulation more easy nowadays. And this is the operating room setup images. You can see here the important point is make a good water collecting system is very important to endoscopic procedures. And you can see some CM view and video operating video view, you can setting like this, and the fluid irrigation system here together. And nowadays we checking the anatomical consideration of in the endoscopic spinal decompression. And we already well known that the ligament flower made by the outer layer and the inner layer, but we should more focus to this inner layer because of this inner layer more deeper and more close lateral to the foraminal space. Because of it, we need more sufficiently inner ligament flavum detached to take a sufficient decompression and decreasing the recurrence. And another anatomical consideration is that this ligament flavum anatomy some changed from the low lumbar and upper lumbar. Upper lumbar ligament flavum is more stiff and more narrow. And rather than the lower lumbar more wider and more wider ligament and more less angled ligament flavum. Because of it, if we try the lower lumbar level, we need more longer distance ligament flavum process needed, but in the upper point, more steep process than needed to detach the ligament flavum in the layer. In the endoscopic view, nowadays we can see some two part of the docking point, this cranial lamina point and this caudal lamina point. I used this caudal lamina point because of that docking to here more steeply docking can decrease muscle bleeding because of that. At the beginner, usually some muscle bleeding is very difficult to manage, because if you close docking to this lamina, you can decreasing the muscle bleeding, and operating bleeding can decrease and more easy. And also approach also some can possibly divide to this translaminar approach and sublaminar approach. I'm also used this sublaminar approach because of that. This is more easy to detach the ligament flavum and the sufficiently preservation of facet functional segment. And in the anatomical endoscope view, we should remind that some important point, 3 point of V point. You can see this V shape and this V shape and this V shape will be this V shape and this V shape. You can see here, and this V shape, meaning the landmark of this two midline. This here is ipsilateral facet starting point. Because of that, checking this anatomical landmark will be very important to how much your process going the ipsilateral or contralateral side. And you can see this info from this paper of the neurospine written by me. And also in the I use the outside in drilling over the top technique. In that process, most important point is that the drilling of the bony structures. You can see here the ipsilateral cranial and ipsilateral caudal, and the contralateral cranial and contralateral caudal, like this process. You can see like this way. And then after that, you can go to the more deeper point of the contralateral foramina. Sometimes contralateral extraforamina is possible. And this is a concept of intraluminal contralateral foraminotomy technique. And now we're checking the surgical process, endoscopic decompression. Endoscopic decompression approach can possibly divide to these two techniques of under the top technique and over the top technique. Anyway, nowadays most doctors like over-the-top technique, but maybe if not you're not expert and some starting point, this under-top technique also very useful because firstly you will meet the ligament problem and cutting the ligament problem, and that starting will be more easy. But this technique have some chance of some incomplete surgery, some resection of ligament problem, sometimes not insufficient. Because of that, if you're some expert, then you try this over the top technique, because this over the top technique, if you expert, not only apply to lumbar, but also you can to the thoracic and cervical more safely apply this using this over the top technique. Like this, okay. And also, you can see here one more time this ipsilateral of decompression and contractor over top. And sometimes you can change this large scope, and sometimes change small scope, and can possible more deeper point approach is possible. And now we remind the process of ipsilateral cranial, ipsilateral caudal, contralateral caudal, and contralateral cranial drilling is really very important to do. This laminectomy procedure, very important procedures of endoscopic decompression. And you see some endoscopic anatomical views. Firstly, docking the ipsilateral facet area and during the ipsilateral lamina and cranial part of lamina and caudal part of lamina, and over the contralateral side, and then during the contralateral side, cranial and contralateral caudal decompression. After then, take out the ligament flabrum. There is a concept of over the top endoscopic decompression procedures. You can see here the firstly drilling of the ipsilateral cranial, then go to the to caudal, and you can see there's some V point of midline here. And then you can see detach the over the contralateral side and detach the contralateral outer ligament flabrum. Then go to the you can detach the cranial tip of the ligament flabrum. This is very important point of finishing the cranial tip of the ligament flabrum. This if you success the completely decompression of the spinal stenosis, this detachment of the cranial and caudal and ipsilateral contralateral lateral access point is a very important point in endoscopic procedures. And then final decompress the bilateral lateral access point. That is the final point of the procedures. And now we see this illustrative image. I will show that. Firstly, yes, marking. Then insert the guide wire. And then you can see this view. Firstly, drilling the cranial, ipsilateral, and the contralateral caudal point. Then overcome the contralateral side, cranial and caudal. Okay, and also you can see another video in the neurospine. You can see this video, neurospine journal. And also we can use the, I already mentioned that we can use the large scope and small scope, channel switching, or sometimes a channel in channel technique that is more easy to approach the more deeper point of the contralateral and ipsilateral side. Like this. And we should remind that in the endoscopic decompression, check the 3V point and detach the cranial and caudal ligament problem and sublaminar drilling, sometimes channel switching technique. And then nowadays, many endoscopic surgeons tried this butterfly ligament problem detach procedure. So this is very important to cutting this cranial and caudal ipsilateral and contralateral part of the ligament problem. But anyway, endoscopic spine procedures also have several complications. Among the most common complication is a dual tear. In my study, there have, in spite of the become a master, I'm also have a 80% of a dual tear, but fortunately, this near all dual tear can possible more easily patchy blocking technique. I use the taco seal patchy, and then you can see the like this severe dual tear cases also with the taco seal patchy blocking technique can easily manage this dual tear cases. Finally, I will see the sum of cases. Nowadays, I already mentioned that not only lumbar, but also thoracic and cervical decompression is all possible using the endoscopic decompression. This patient is 80-year-old, very, very severe spinal stenosis cases. You can see the firstly ipsilateral cranial and now during the caudal, and now go on the contralateral side, detach the outer ligament problem, and finally detach the cranial tip of the ligament problem here. Then take out the ligament problem. Then you can see take out ipsilateral and contralateral ligament problem together. Then you can see the post-operative image you can see here. And also like these cases of the some stenosis with these cases, sometimes you can see here that some channel switching technique, large, firstly try the large scope, then change the small scope, then you can see more easily manage the more detailed procedures. And also like this processes cases also endoscope approach, the contralateral approach is more easy compared to the open procedure. So you can see here. And also you can see this case is upper lumbar L23, very severe stenosis cases also more easy in spite of the like this severe cases, post-operative you can say sufficient decompression, fast preservation is possible. This is also very important. You can see after detach the cranial tip of ligament problem, you can see here is a contralateral shift process. Then during there, detach the cranial ipsilateral border of the ligament problem, then you can take out the ligament problem by the one piece. You can see here. Then you can make like this butterfly ligament problem take out. This is very important to decreasing the dual tear and some sufficient decompression cases. And also now we can it's possible to lateral approach, not only decompression of the ipsilateral, but also lateral recess and contralateral foramen and the contralateral extraforaminal decompression by the one spinal pressures can possible. You can see the contralateral foramen here, the exiting nerve root, and then you can see like this cases, in spite of this degenerative deformity cases, foraminal pathology is possible. And also, I already mentioned that these procedures can possibly apply to the thoracic procedures, decompression cases of the, and also can possible cervical decompression is also can possible. You can see after them. Sorry, you can see that sufficient decompression is possible. Okay, in conclusion, yes, before time we endoscopic spine procedures mainly target to the endoscopic dissection because of that we know that there is the advantage only early recovery, early ambulation, and less anesthesia and cosmetic effect. But fortunately nowadays more developed so much, and nowadays the advantage of endoscopy procedures that can preserve the functional segment completely because of that. Before time, we only focus the MI treatment procedures, endoscopy procedures, but nowadays we can go on the functional treatment period. Thank you for your kind attention.
Thank you so much, Dr. Kim, for these great presentations. I know you are a great endoscopic surgeon. Thank you so much. And we will